Right, and next up, which moves seamlessly on, Kenji, Simon and Jenny, who are going to talk about connecting wellness, urban form, care models and health outcomes.
I'm here to talk to you today about some research that we have conducted in Cranbrook. It's been really interesting working on a new town, obviously. It provides opportunities and it sits within an existing context, both legislative, political, etc. So it's a challenge. And the opportunity that came through HNT was really good. It brought together a whole series of different organisations to work on a complex question, which actually isn't a complex question, it's a complex answer. And the ability to work with space syntax was particularly important. I think Virginia's already outlined what's interesting about Cranbrook. It is, out of all of the healthy new towns, the only one that is, I suppose, representative of the norm. It is the example that is, I suppose, representative of almost the vast majority of the way in which housing is developed in the UK. And so the answers that we derive here actually can be applied across the UK. So it's really important that we try and explore these particular questions here. Also, it means that we will be rightly challenged by the developers. It's their interest as well as ours. And the more they challenge us, then the more likely it is that we get things right, probably. Got to live in hope. So, I think the first question that obviously arises is, well, how do you build a happy, healthy town? I think when you look out there, you can see there's vast amounts of policy and guidance and helpful things that tell you just how important it is to get it right. You can read through it all. It's very interesting. It won't tell you how to get it right. It'll just tell you that it's really, really important that you do. This is actually not as helpful as you might think. It does cause a lot of head scratching and thought. So one of the things we were wanting to do here, and the opportunity that we had with space syntax and with especially the work done by Public Health Devon, was to draw together evidence, both from in terms of the development of frailty in people and how people interact with place. The question really is about what is it exactly that places do to people to make them either happy and healthy or not so happy and healthy. I'll leave you to work that one out. It's a particular bugbear of mine. Anyway, so on the left, I think it's Basingstoke. I feel terribly sorry for Basingstoke. I'm always very mean to it. And the other one is Lou. And I suppose the question that comes up is that, if we're following guidance, why are we doing this? Why does this arise? What is wrong with what we're saying? Because all of this guidance is written from the best of intentions, it's written by very intelligent people, it's written on the basis of some research, but I'm not entirely sure that the answers that we're coming up with are the right answers. We couldn't develop Lou anymore. If we tried to follow the guidance, we would be in direct contravention with a whole load of things that are telling us that Lou is terribly bad. But I think the people who live there quite like it. So, what's the problem? I mean, part of the problem is that the built environment is exceptionally complex. We live our entire lives in buildings and the built environment. There are many things going on in it. So trying to separate things out is never going to work. You cannot test individual aspects. So I suppose we have the ability here with vast data sets to combine them within a model to understand really how they interact and then perhaps to start to get some answers. Part of the problem was outlined by the Design Council in 2017. They conducted some research. The clue is actually not in the name. This document, Healthy Placemaking, was actually talking to about 600 built environment professionals about why this doesn't happen. And there are many actually, well, quite interesting answers about why it doesn't happen. And it was about barriers and all that sort of thing, which I think are there, and I think they're real. But actually, part of the problem is actually we really don't know. We don't have the evidence. We don't know the answers about what sort of built environment is the best for health or well-being or whatever. When we visit towns, I think we have, I suppose, an innate feeling about what we like. but we don't know whether what we like is good for us. And I think that's a very interesting question, because we think we know what we like. When we ask, or when we are asked questions about what we like, we will come up with interesting answers, particularly like parking. We like parking. Do we like parking? Is parking good for us? When we look at the highest value places in the UK, do they have any parking? No. So this is and so does value follow health? Do we value the things that actually make us healthy? And this is all conjecture. When we go to a place like Gandhi Street, that's the one in the middle, we like it. Is it good for us? Why do we like it? When we look at the one on the left, that's just outside Milton Keynes. I'll try to keep it as far away from here as possible, just to be lucky in contention. Anyway, so just outside Milton Keynes, there's a place which I'm going to beat with the bad brush. That's the result of guidance. That has followed all of the things that we think we like. It's got plenty of parking. It's got low maintenance shrubbery, so you don't have to actually make any effort whatsoever when you come home. You go inside, shut the door, turn on the TV. Do we like it? And then on the right, that's an example of a developer breaking the rules. It's Poundbury. It's, basically everybody loves to hate Poundbury because it follows a sort of traditional architecture and all of that sort of stuff. And then Prince Charles is involved, so we get to have the political thing. But actually, Poundbury's really interesting. If you take the fluff away, if you ignore the architecture, the pastiche, and all of that sort of thing, it's asking a single fundamental question. How do towns work? How do we take the model apart, put it back together again? And it's asking the question, are old places, the places that we've been building for millennia, places that are actually good? We don't know. So, we have an opportunity within the research, within the model, within this space syntax model, with the data set that we have from Public Health Devon, to overlay these two questions and about health, about the built environment, and try to understand actually, do we, or are we able to, I suppose, understand innately what is good and what is bad, and translate that into quantitative evidence about how places impact our health. There's a difference, I suppose, in terms of that data. We can ask people, do you like this place? And they'll say yes or no. We don't tend to believe them. We all will be able to say yes or no to what we like or what we don't like. But because it's not quantified, because we're not able to then say, but actually, is this real? It's just an opinion. It's ignored. We might be able to actually put the quantitative data behind that. We might be able to say, actually, this is good for you. This is bad for you. You like the places that are good. Maybe I'm wrong, because that's just my idea. The amount of data that we have and the opportunity we have here is actually going to enable us to address questions that are actually really simple, but are extremely difficult to ask, or actually they're very easy to ask, but they're extremely difficult to answer. We might be able to start getting answers to, particularly things about density. If we say something, urban designers love high density, everybody else says it's awful. Who's right? I think I want to win the argument. But anyway, I might be surprised by the answers. I've got to be open to the fact that I could be contradicted by the research that we're doing here. My good ideas might be wrong, and we have to be open to that. And this is the opportunity that we have. Simon will tell you more about some of the nitty-gritty.
Thanks, Kenji. So, as described by Anna earlier, the integrated urban model provides us with understanding of a place and how it functions. So, our job was really looking at how urban form might impact on the health and well-being of the population. And we did that for an established community of Exeter, so we could really see how that interaction worked. So Integrated Care Exeter, or ICE for short, was a programme which focused on community development and service redesign, and within that we developed a linked data model. Now, in this linked data model, we took information around the health of the population, so frailty-based risk stratification was at the core, so we could describe those at low, high or increasing risk of becoming frail. But then this was linked to a whole plethora of information on health activity, health outcomes, but also household characteristics and social characteristics in the population, so we could start to kind of inform work on our planning. Okay. So, in terms of bringing the integrated urban model and our work from ICE together. So here's an example of analysis from the integrated urban model. So as Anne described, there's various measures in there relating to access to services, car dependency, walkability, and the availability of different services to a population. And this map, we've got a kind of shaded road network in the background, which shows us the access to services measure. So this is looking at the variety of different services which are accessible from locations. So where we've got red shadings, we've got a great deal of land uses available to the population. Where we've got blue shadings, we've got a kind of limited access to services. So we see a high density of access in the city centre and a few centres as well dotted around the city, but there's other areas which are kind of very blue, typically on the outskirts. The shaded map in the background, the grey shading, shows us the indices of deprivation from the index of multiple deprivation. So we can see how kind of that overlays. So in terms of our data from ICE, this looks at frailty. So, and this frailty we can define as a state of decreased function and activity. Now, frailty, many people think frailty equals age. It doesn't. Whilst frailty does increase with age, what we see are some people living to a grand old age while still remaining predominantly very active and well. But likewise, we find people in younger age groups having a much earlier onset of frailty. And part of that pattern around the early onset of frailty is linked to deprivation in our neighbourhoods. So our more deprived communities are likely to have an onset of frailty about 10 to 15 years earlier than those least deprived communities. But when we started looking into detail on this map, we found the deprivation pattern largely followed, but there are actually a few areas which appeared to buck the trend. And they're kind of circled here. So let's look at these two maps together. We've got these three areas here where we've got limited access to services, low deprivation, but actually a higher level of frailty. I will note as well, the frailty map is age standardised, so it shows us where that kind of early onset of frailty is. So the kind of red and orange shading show us early onset of frailty in our communities. So we started looking into the characteristics of these populations and what their kind of common features were. And what we found is that these were post-war, post-World War II suburbs, so largely developed between the 1950s and the 1990s. If we looked at the neighbourhoods, they were highly car dependent, so the design of the road network was built around the car. And we also found that these were communities which had a household composition which was mainly around couples and families with teenage children or adult children. When we looked at the wider data in our model, so part of Integrated Care Exeter was around highlighting social isolation. We found that these areas were also at higher risk of social isolation and loneliness. We also found in a couple of the areas which were particularly hilly, the kind of road network led to very long linear streets and limited connections between areas, so that came through as well. Okay, so I think one of the main things from our wider analysis when we take the full data from the integrated urban model and the full data from Integrated Care Exeter was the really strong correlation we found between obesity and car dependency, which I think is reflected in some of the evidence that Anna presented earlier. Local walkability is also absolutely critical. So even where a community may be very car dependent for work, local walkability was still important as a protective factor in terms of people's health. And I think a kind of story starts to emerge when we look at this kind of suburban form is that what we find in these areas which are more car dependent is people are less likely to be active. And then we tend to get an early onset, particularly of mild to moderate frailty, which will often actually trigger a move to a more central, accessible location or into care homes or other kind of supported accommodation. And what you get is a kind of movement of population. So all the health outcomes which may be associated with living in a neighbourhood aren't necessarily realised in that neighbourhood. They kind of follow on. So understanding that course is really important. And this is why it's really important for Cranbrook. Because at the outset, a new community will often have a more kind of fit and active population in terms of those who are able to kind of move and migrate to particular areas. But over time, that impact on health will become more apparent. So, and that can take 10 or 20 years in the community. What that reinforces is we really do need to think about planning for the future and the kind of findings which were discussed earlier around car dependency in new towns, and kind of really consider these now in terms of how we plan things and how we do things. So, a little bit about further analysis, and this is, I think, only really the start of our work, so we're going to do a much more detailed analysis of this data at below a neighbourhood level, so we can start to kind of really get into the detail of this and look for other patterns. That'll be enabled doing something we're developing called the One Devon data set, which will be a kind of wider, more sophisticated linked data model for health and care. There's also an opportunity to link this in with the Sport England local delivery pilot, so the information we might be gathering there on physical activity and the availability of different services for people linked with this could be very powerful, so we're kind of actively looking at that within the programme. We presented our findings as well to the Salis Healthy City Design Conference, and that kind of went over really well, so opportunities for collaboration and publication are coming out of that. And I think what it really highlights to us is the opportunity to build on this work that the new Healthy New Town programme has enabled us to do is really important and is really influential in terms of how we can, I guess, influence the wider system. So I'll hand over to Jenny now, who's going to talk about some of the wider impact of our work.
Right.
Yeah.
Oops, no, what to say. Okay, thank you. Coming from the NHS and listening to some of the previous speakers talk about NHS engagement, I need to say that this work, being involved in this, has been so interesting, but also makes you realise how many opportunities we could miss if we weren't engaged early on with wider partners. And so I'm going to talk a little about, what impact it could have and what we're trying to do. So starting with, we've talked about the data, and the data analysis is absolutely crucial, but it's how we use the data, how we approach what we're going to do that will really make an impact. And so 4 areas that we think, having been involved in this project, are really, really important. And the first is the people, and thinking about what are we trying to achieve here? Who's the population? What do they actually need? We're trying to get better health and well-being for a community, and so to do that, we really need to keep that focus. And any of our conversations about the data always turn into a conversation about, well, what does that mean? Can we apply this in Cranbrook? Can we apply this in other places? And I think that can't be underestimated. Partnerships, the second, easy to say, much harder to do. And I think something we've realised is getting the understanding of each other's worlds is really important, because we can actually do more together. And I'd never appreciated quite how much planners and designers and community leaders were really interested in finding solutions to make health better. And so coming outside of the NHS and looking at it, we can do much more together, and I think that's where we're going with this project. Places, you've heard already this morning about the growing recognition of the key roles places and communities play on health and health behaviours. And so the understanding of the way people live their lives in the communities through space syntax and through this work actually helps us to say, well, what should the model of care support be, as well as what should the design of the built environment. And then the last is thinking about our plans. We've got a multitude of plans, whether it's, master plans for housing, NHS plans, other plans. And what we're discovering is there are some things that if we plan together as part of this work, we can have a bigger impact. So how do we design health for this community, drawing together the way that the built environment's been thought about and our healthcare knowledge. And so we think it brings new opportunities, and as you've heard, we've put together different evidence, put it through a sort of number cruncher, and came up with connected data and new insights. And so as a result, we're thinking differently about urban design and how Cranbrook and other communities could be designed around improving health and well-being. You know, what is the accessible approach to services? How do we plan for the wider determinants of health and to address frailty? And we're also thinking quite differently about the health models and turning things on their head a bit. So the discussions that you've heard about walkability and being able to access support, we're thinking, well, what do we need to make accessible in neighbourhoods? And this is much more about well-being services and well-being support. And there's a good example in Cranbrook, a really good example of the pharmacy who have extended their role and you know, infant feeding and you know, other support, making that sort of thing in neighbourhoods and accessible, and working with a wider workforce than traditionally there. So we are thinking differently and acting together. And as well as sort of looking at what we do in Cranbrook, there is the debate about, are we learning things that can actually change policy? And so drawing together existing policy, what we're learning now, applying our relationships and understanding and opportunity to test. And, you know, is there a future set of design guidance? Is there a future opportunity to learn? And certainly the inquiries we've been having is suggesting that we've probably learned more than we had appreciated at the beginning. So next steps, dissemination. So sharing the learning from Cranbrook with wider groups, and we think that's really important. Today's been a great opportunity to do that, and we've had other opportunities, as Simon said, and so we want to just keep talking about it, because the more that other people can look at the information and challenge it, the better it will be. It will answer the question that Kenji posed at the start. So sharing learning, building consensus, so looking at the data, is it strong enough, is it robust enough, what else can we do with it? And then actually making a difference, making an impact. And I think I'll leave you with that. That's what we're trying to do.